Welcome everybody to our most recent webinar put forth by the BRCA and Hereditary Cancer Program. Today's focus is on mutation variants for males and treatment and testing for males. I think we are really excited to do this. And before I introduce my panelists, I'd like to thank the Lynn, who has done an amazing job inviting everybody. Dr. Letitia Taniwaki, who has helped with putting the program together and has been instrumental in making this happen and getting our panelists invited. And Danielle Sipes, who is really good at making these amazing flyers. So before we start, this is an effort that has been sponsored by a very generous donor, this donor being here. So Gordon, I don't want to put you on the spot. I do want to be grateful that you make this webinar happen. I would like to start before we talk about the patient and community representative. I'd like to invite Julie to say a few words of who you are and what you do.
Thank you. I'm also really pleased. My name is Julie. I'm a genetic counselor here at UCSF. I've been here for 22 years, but for the last 8 or so, I've had the privilege of working with this amazing team to build a really comprehensive set of medical care and support for people who have genetic risk for cancer. And I'm just couldn't be prouder to be part of this team.
Hey, Marta.
Yeah, hi, hello everybody. My name is Marta. I'm another genetic counselor. I work together with Julie. I can't do anything else and echo how wonderful it's been being part of this clinic and group, and how interested we are in really trying to provide and make the best for all of our patients.
Thank you, Marta. Beth?
Good evening, everybody. My name's Beth Lynn. I'm a nurse practitioner, and I see a lot of the patients in our hereditary cancer clinic. And I'm very excited about this session this evening because I worry every day when I'm seeing patients that we have a huge 1,400 people in our clinic, but that we have so few men. And so any way we can encourage men to do testing and to receive the appropriate care is my #1 goal.
Thank you. And I'm Pamela Munster. I'm the director of the BRCA and Hereditary Cancer Program. This effort was founded on this really strong need that we have mutation carriers seen early, prevent cancers, and so that in the futures we do not need to have patients present with preventable cancers. And I like to hand it over to Cary Cole, who has been and very early, very highly proponent, representative of testing and getting care. Cary, say a few words about yourself, please.
Yeah, so I'm just honored to be here. Pamela is my oncologist, but also kind of my primary physician, and she takes great care of me. I'm a 18 plus year cancer survivor. I have a BRCA1 mutation, and I'm just honored to be here and help as many people as we can tonight.
Gordon, you have been one of our strongest proponent, and I've seen you gone through an amazing journey. It's like, please say a few words and thank you for being here.
Well, I'm happy to be on the program and to share my particular background. I'm a BRCA2 carrier. My daughter was first diagnosed with breast cancer, and by that time testing was available, and that's how I found out that I had BRCA2 mutation. And it's been very important to my family that we know about that going forward.
Thank you. And then Max, your our youngest proponent. It's great to have representation from young participant. You have been in this program before, and you have been very elegantly spoken about why young people should get tested. Please say a few words.
Hi, I'm Max. I'm not quite as qualified as any of the other panelists, but hopefully I can add some perspective for the youth that might be useful.
So before we launch into like a really an important point for me is men get cancer and men are fathers, and I think this is really the overarching reason why I think males should get tested. But let's hear a little bit from our genetic counselor first. Is like Julie and Marta, why should males get tested? What are the most common cancers for BRCA1 and BRCA2 and other hereditary mutations? Start with Julie, maybe.
Yeah, and I think Beth, I want to sort of follow up on something that Beth had said earlier, that we do still see a lot more women or people assigned female at birth in our clinics. But I will say I saw more men in the first year of working in this clinic than I did in the prior 14 years of being a genetic counselor. So I think I don't want to stereotype. I think every person's an individual, but generally, I think in a general sense, I think having something concrete, having somebody like Beth who can actually do something with these results has really changed the approach for a lot of people. In answer to your question, the genes that we've been talking about, BRCA1 and BRCA2, when someone has a mutation, do still carry much higher risk for women than they do for men. So for men, what I always start off with saying is the highest likelihood, if you are positive, is that you actually don't get cancer from this. But there are some cancers that you are at increased risk for that if we know about it, we can monitor. And those, the top of those is prostate cancer. But we do also see some other cancers like breast cancer, pancreatic cancer. So it's partly for your own medical care. And partly also a lot of times that's the key to helping somebody else in your family. So I think that those are a lot of things that I think of as important messages for some of the men that we work with.
And Marta, is there a good time frame when a man should get tested?
Yeah, that's an interesting question, and that's what kind of was coming to mind as Julie was talking. I think like historically this question has evolved. I think in the past, really the idea was that the impetus for testing was really more related to family members and do I have daughters. There was a strong focus on female within the family, and we used to have to say much more that the testing was for the person, not just for the rest of the family. But in terms of like a testing window, we talk to patients from their like 20s, early 20s, all the way to someone who, like Gordon, found out about the mutation in the family because someone was diagnosed and so is doing more family testing related. So there is no perfect timing and there's no wrong time for testing. It's really what we try to do is support everyone and try to understand what the right time is. In terms of screening, we don't start screening really for men before than age 35. So a lot of people put that as their sort of like time frame. On the other hand, as Julie was mentioning, we always think about family planning. So we see a lot of people younger who want to know, like, do they have this mutation? Is it something that they need to think about and talk about? Or is it something that they should be aware of? So really, any time is a good time.
Right. I think what we usually are, what I feel very strongly is that whoever gets tested is ready for the testing and dealing with the consequences of knowing about the mutation and really undergoing screening. So Beth, when someone with a BRCA1 or BRCA2 mutation comes to your clinic, what do you do with them?
Well, the first thing we do is talk about their family history and what types of cancers they've seen in the family. And then we talk about kind of a screening plan. based on their family history and based on their age. Depending upon an individual's age, we start with prostate cancer screening. We do that earlier than men ordinarily do in the general population. And we manage it very differently. UCSS has some amazing urology oncologists who have some great tools about assessing risk in prostate cancer. So we monitor the PSA results, the prostate surface antigen result, the lab test. And when it's elevated over like a level of 1, which is a completely normal number, we refer people to the specialist to do a secondary evaluation for risk. So what we're doing is we're monitoring more aggressively than would be done in the general population. There's a lot of education about symptoms, like what kind of things to be on the lookout for, when should you contact the office. We teach men how to do breast exams and what to look for in a breast exam, and basically answer any questions they have about, family members, what kind of screening they should be getting.
Thank you. Going over to Cary, your testing and result was a bit on the unorthodox side, if you will, right? Can you tell us a little bit why you got tested and why you feel strongly that men should get tested?
Yeah, this is a pretty difficult story, as Pamela knows. But so I got colon cancer and then was tested. Stacy, my wife, was like, hey, you should get tested. It was, 18, 19 years ago. So these tests were kind of becoming more popular. And then we found out my mom had it. And then, we started testing, aunts have it and this sort of thing. And we have 4 kids, 2 older boys, 2 younger girls. The older boys out of college were both tested. And at 29, the older child, Michael is his name, was diagnosed with stage 4 pancreatic cancer at 29. So I don't agree in personal experience that you should start testing at 35. That's like maybe the single worst case scenario. And there's not a lot of 29-year-olds in the world with BRCA or anything else that are diagnosed with pancreatic cancer. But as you guys know, in your clinics, there's a lot of young people with colon cancer and a lot more younger people getting pancreatic cancer. So, I'm a firm believer in more testing earlier. I'm also an investor, kind of an executive in the medical technology industry. And there's some really exciting things happening with multi-cancer early detection and artificial intelligence against different radiology. We can find these things much earlier. But as Beth said, and Marta and Julie, it's about a plan. Every family's different. Every person's different. Some people don't like the data. Some people do. But the risks are there. And I have the story of maybe an outlier, but young men can get very serious disease at a young age. So I say more testing, the better.
And I think your family story really also drives home is like, even if right now we don't do any screening program under 30 for your son, the fact that we knew he had a BRCA mutation, but everything was very streamlined, right? The therapy was tailored. He got on a PARP inhibitor, I think so. So knowing was really significantly impacting his care, actually.
Yeah, no. There's actually a very good ending to this story. I mean, it's a challenging story for him for the rest, but he's now 31. And because we knew he had BRCA, because we had Pamela Munster on the team, because he has a really great oncologist in Arizona, we were able to tailor the chemo cocktail for him and then give him a daily PARP inhibitor. And now he's a year and a half later, and he has no active cancer in his entire body. And this was after it was in the pancreas, all over the liver, moving to the lymph nodes. So, what you are doing kind of from a research and treatment, is incredible. It would have been better to catch that earlier, like stage 1. It's worked out really, really, really well so far because of the science that's being done at UCSF and other places. But, strangely, I had colon cancer. So even at a young age in his 20s, he was getting colonoscopies, but we never even imagined to do like some, MRI pancreatic test or something. But hopefully these multi-cancer early detection tests in the next, 5 years will be out there for things covering all the BRCA cancers, all the hereditary cancers. So people at risk can work with Marta and Beth and Julie and just kind of get more aggressive if that's what they want to do.
So going to Max. Max, you're like 24, almost 25. You got tested pretty young when you just heard you didn't actually need to get tested because not really much to do. Why did you get tested?
For me, that was kind of a two-part thing. The one is I have a younger sister, and I don't exactly know the math behind it, but me getting tested kind of gave me a better idea of what her risk would be, even though that's not really how math works. And that was one of the reasons that I used to justify getting tested. And then the second reason was that I felt like I was able to handle it and wanted that information because I think it would be helpful in the event that something happens or to help me make better decisions in the future. And that led to my ending up getting tested.
And right now there's not much to do for you, and I think do you feel the knowledge that you have the mutation that you would know where to reach out to if something did happen to you would be helpful?
I mean, for sure. I think it's just the fact that I know means that it sort of helps me if, again, there's like something that I see that's not normal, it kind of gives me an idea of what could potentially be behind that and obviously what resources are available to go down.
Okay, thanks. Gordon, you also got kind of like got testing via a female relative, right? Can you talk a little bit about what happened in your family?
So I'll go way back to my mother, who got breast cancer before there was any knowledge of the BRCA genes. And she, I often think, would like to know where things are today that we know, because she couldn't understand why she got breast cancer, because she lived what she thought was a healthy life and didn't drink alcohol much, and she ate healthy and didn't smoke. So she was perplexed. And, I had prostate cancer before I was diagnosed with being a BRCA carrier. So the first wake-up call was when my daughter got breast cancer. And that was probably about 18 years ago. And genetic testing was pretty new, but the two BRCA genes were ones that could be screened for, and we knew the link. So as soon as she was tested, it was pretty obvious with what your counselors at the cancer center at UCSF said. They said, well, you should be tested to find out if that's where it came from. I do have a Ashkenazi Jewish background, which raised suspicion, and sure enough, I was positive. So I have 4 brothers. I encourage them all to be tested, and 2 of us are positive, 2 are negative. That was very informative to us because some of us have sons, some of us have daughters, and that allowed the offspring to be tested as well. And some grandchildren are now in play, and so we know who has, for the most part, who has BRCA positive and whose doesn't, and we have one 21-year-old who hasn't been tested yet.
So, Gordon, if you think back, if like when you were tested, before you were tested, Was there anything that you wish you had understood better or like you had more information about?
I'm glad that I lived in the Bay Area and had a relationship with UCSF. So I was lucky in that sense. I think at the time, 20-ish years ago, if I lived away from a medical center, I wouldn't have had the information. And that's what I think is so special about your program is you're getting the word out beyond the hallowed halls of academia.
Thank you for that. Cary, what about you? It's like
The history?
yeah, what I mean, you know, when you finally knew that you were a BRCA carrier, like what would you have wished that you had known at that time as like what would you have done differently if you had known before?
Yeah, I mean, I wish I would have known earlier. So I kind of went through this 9-month process where, you know, you have gas, you have irritable bowel syndrome, you have lactose intolerance. I was like, really? Like, you know, so I go a month, all these tests. And finally I was like, you know, I may have colon cancer. Like, no, you have no blood in your stool. I'm like, but maybe. And then, you know, so finally I had a colonoscopy and it was like 99% occluded my colon. And, you know, it was really painful. So I think if I knew earlier, kind of like what Max was saying, if he felt something, he would know like, okay, maybe this is related to that problem and it would help me be more proactive. You know, once I found out right away, I tested, you know, my brother, my sister, my mom, and like, you know, some had it, some didn't. And now we're like Gordon, we're on the next generation, and some are a little too young to be tested yet. But, you know, the older ones, they're getting tested. And this is ricocheted through multiple levels of our family all around the United States and in Europe. And, you know, we just have it. Like approximately 50% of us have it. And, you know, I think all of us are pretty happy we know, and it's letting us be more proactive, you know, from a prevention, from a monitoring, from a, so to me, knowledge is power, and I want to know. And you know, I have daughters that are 15 and 17. The 17-year-old wants to know already. I'm like, no, that's just too young to know. But at 18, I'm like, you graduate high school, if you still really want to know, at 18, you could make that decision yourself. So
Max, you were how old when you were tested? You were 18 or 19?
I'm 19.
And did you feel you were ready?
Yeah, I mean, pretty much.
And you know, I think Cary is like I had long conversations with Max and also with my youngest daughter when it's the right time for testing. And I said this before, when I was first diagnosed with my BRCA mutation, all I could think of is like I wanted to test my kids, right? I just really wanted to know. But what I really just wanted to know, are my kids okay? And then as you know, I run a lab. I could easily test any of my kids in the lab and do this. And I had great plans for this until one of my nurse practitioners said to me, but you can't keep any secrets. How are you going to keep this secret? And I was thinking like, yeah, how would I keep this secret? And then I really came around. This was a big process of mine, just letting my children be ready for this when they're ready. And like, I think it made a big difference. So, and I also have to say what Harry said is like, you know, when my father, who I knew was BRCA2 positive, when he presented with some kind of abdominal cramping and bloating, there was no 9 months of like, you could go on an antacid, you can do this. It was very clear. He gets an MRI of the pancreas. It was just, that was before. So I think this is for those participants out there who are struggling. Should I get tested? Was it matter? I really don't want to know. The key really is we take every one of your symptoms really, really serious, and we very carefully evaluate for diseases you might have, so we don't let you struggle.
Dr. Munster, can I add one thing that I often discuss with my patients as is related to themselves, but their family members? I strongly encourage everyone to have their family members go through genetic counseling. As genetic counselor, genetic counseling and genetic testing, they're not equal. And we prefer actually seeing people before they make a decision about testing to facilitate the process, help them identify when the right time is for them. And if that's not the right time, have a plan for them. What do we do in the interim? Where we go from here? And so we don't want for people to struggle out there on their own in deciding when the right time is. And I tell all of my patients, we're here for them. And while we normally talk about early 20s to start to have a conversation, I have so many patients who are like 18 and they come and we talk about what are some of the considerations, how do we get to that point, and how do we decide what's right for you. As you said before, there's no perfect time for everyone, but we're here. And even if someone decides not to test, we are part of the team and we're here to support everyone in their process of genetic testing and genetic knowledge.
Before we go to some of the questions that the panels ask, Gordon, how do you talk to your granddaughters? You have accumulated a lot of knowledge and you've seen a lot, particularly having 2 family members have breast cancer. How do you talk to your granddaughters about it?
Well, the granddaughters are well aware of it because most of their lives they live with their mother's disease and are passing. So they have a degree of intimate knowledge and fear. One of the granddaughters has the oldest 2 granddaughters were tested probably but they're between 18 and 21 sometime. One's negative, one's positive. The one that's negative is, scot-free, so to speak, and that burdens off her shoulders. The other one has internalized it a lot, and she's moved out of state and has sort of told me that she's taken care of it on her own and distanced me from what she's doing. And I think it's highly emotional for her, and I don't really know what she's done. And the youngest granddaughter, really wants to get through college. She's a sophomore, and then she will be tested. So she's thought about it, and it's not the right time yet for her. And she knows that there's no rush up to 25 or mid-20s. But in my case, to backtrack a little bit, when I was informed of my mutation and told what my increased risks were by the UCSF genetic counselors, I began immediately doing annual breast exams, even though the risk for males is much lower than females. And of course, I'd been doing PSAs and I'd already had my prostate removed, so that was a bit moot. But whole skin exams for melanoma is an annual thing that I've been doing. And recently, I joined one of your research programs for pancreatic cancer screening to see if the MRI is cost-effective and useful. So I've been very proactive in using the screening and it gives me peace of mind, even though you'd wonder if an old guy like me even worries about it at this point, but I do.
Yeah, I think, diagnosing pancreatic cancer at an earlier stage is probably at any time better proposition than at the later stage. I think we can do more about it. I think so. I think you're on the right track, Gordon. I don't want you to change anything. And I think this is what we often see now. We have patients, individuals are more mature, who are 70 and they have a sister who has a mutation. They want to know, do I need to get tested? And I do feel it's important to get tested. It's knowledge that is affecting an individual's care, and it's knowledge that it affects an individual's family members. And I think, so Cary, what about your daughters? When do you think you how are you approaching that? It's like you've been very thoughtful with this.
Yeah, I mean, unfortunately, they've kind of lived with their older brother going through something as serious as stage 4 pancreatic cancer, and just that has highlighted for them the severity and also the risk at a fairly young age. Like, it's not a 40-year-old or an 80-year-old thing. It's like he was 29. So they also have lived with me. So I had it 18 years ago. And, one of the things I believe that I learned from it, I actually look at cancer almost as a positive for me, because I'm much healthier. My diet's much better. My stress levels are much lower. I sleep better. I exercise more. And I hopefully have shared that with them. And I think I have. And they've kind of attached to that even more. And one of the things the 17-year-old says to me, she goes, "Dad, I actually think before I go to college, I should know, because if I have it, I'm going to act in college differently. I'm going to start making better choices sooner." And I'm like, wow, that's mature. Maybe I do want you to know. But you know what? 18 is a young age, but I think, like Max, she has the wherewithal to deal with it. And I think she would make different choices. But, I think for all of us that have these mutations, and all humans at all, like, this is a pretty big catalyst for kind of change. But we've focused on the preventative side on a daily level within our family, and missed it with our older son on the early detection side, unfortunately. But we're not going to make that mistake. And again, with the other daughters, like, if there's a stomach ache, she's getting an MRI. If there's a hurt, for my son, he had like sore back and sore hips. Like, he thought it was because he was working out too much and playing too much golf. Like, none of us connected the dots that which was a mistake. But so I think we're in a very proactive mode. My daughters, they're not going to be forced to do it by me, but I think the older one is thinking about taking advantage of that information to maybe setting herself up if it's necessary. And, my guess is the younger daughter will model her, but we'll see how all that goes.
Thank you so much, Max. Being a U.S. Marines, this is not exactly like a totally risk-free life. We're having a BRCA mutation. How do you look at risk? I mean, you have like, I think my other participants have been faced with cancer, so you have family members with cancer. How do you look at this philosophically?
I mean, I think a lot of the other panelists kind of hit on sort of what you're talking about, which is if you are in the realm of getting tested for a BRCA mutation, you pretty likely have a family history of cancer already. So you've likely seen or experienced other family members with cancer. And I think that sort of automatically changes the way you think about mortality and about risk when it's something so immediate. And it's not that further removed to think about, something horrible happening to my family members, to, what happens if I'm not proactive about my own health? What happens if I'm not, willing to get tested right now and get that information? I also think, especially for men, Cary hit on it really well, but I know for me, like, it would have to be pretty severe for really anything for me to like voluntarily seek medical care. And I think that's pretty common, especially for young men going to the hospital for really anything. I mean, I know from some of the circles I'm in around other Marines that if a Marine's going to the hospital, something pretty bad has happened. They tend not to be people who just do routine medical checkups. But again, I think having that information ahead of time as a young man allows you to be proactive about your health in a way you probably wouldn't be otherwise.
Thank you. So, any of my like it is Beth or Marta or Julie's other question is like, can you divide BRCA1 and BRCA2 a little bit? It's like we have just a little bit back into education mode here. So first, like, Julie, you want to take that difference between BRCA1 and BRCA2 for males? I think we have much more information or knowledge that's in the public domain for girls, but how about for men?
Yeah, absolutely. And I think I want to acknowledge, especially with hearing so many different individual stories tonight that, Max and Cary and Gordon have been so generously sharing with us, that there's an individual family story can turn out very differently. So none of these statistics tell us what the future is going to be, but I can share what we've learned. And this is now coming up on 30 years of research on these two genes. So I feel like these numbers are accurate, but I also want to acknowledge that they don't tell us what's going to happen in an individual family. And sometimes cancer histories can be much stronger or much less strong. So BRCA1 on the whole has lower risks for men. And I should tell you where I'm pulling these from. There's an organization called the National Comprehensive Cancer Network, or NCCN. They have, I don't even know how many, tens of committees on various different things, including one specifically to review all of the research around hereditary cancers. And so NCCN quotes for BRCA1, male breast cancer risk is about 1.5% over a lifetime. So I think one of the questions was sort of age-wise. And that screening, as we talked about, we typically start at 35. And so most of those cancers are going to be happening sort of somewhere between 35 and 70. Prostate cancer risk with BRCA1, again, is quoted as up to about 25% over a lifetime. And that is screening that we started at age 40, knowing that most of those cancers are going to happen between 40 and, later in life. And this is where I definitely, as I said, want to acknowledge, the story that Cary shared, because statistics don't always tell us what's going to happen in an individual family, but the overall statistics for BRCA1 is about 5% of people are developing pancreatic cancer. So it is still a rare cancer in BRCA1, but obviously increased over the general population and something we have to take really seriously. And then I'll be a little quicker, hopefully, with BRCA2. Same cancers, generally speaking. Male breast cancer is up to 7%. Prostate cancer, huge range of estimates, the high end being 60%, which may be an overestimate, but it's definitely increased. And then pancreatic cancer up to 10% with BRCA2. And then I did hear skin cancer reference, and there's NCCN feels that the data is a little bit unclear, but we do generally talk to people about melanoma risk. And we also think about, which I'm sure we will talk about at various points, that we think about what the level of risk is, and we think about what tools we have. And with skin cancer risk, we have a really great, easy tool that's not expensive, that's not invasive, that's not risky, that doesn't have a lot of side effects, and that's wearing your sunscreen and getting a skin exam. Some of these other cancers, we need to be really careful to balance what tools do we have versus what the level of risk is.
Thank you. And Marta, can you talk a little bit of how much BRCA1 or BRCA2 or is present in the population? Is who's at risk?
Yeah, that's a good question. We know, as Gordon mentioned before, we know, and a lot of people have heard that there might be in the individuals with Eastern European or Ashkenazi Jewish ancestry, there are some mutations that are more prevalent and makes the presence of this mutation in the BRCA1 and 2 gene more high, but also more known. And so a lot of people that I see in clinic come thinking, oh, it's something that they've heard about in connection to the Ashkenazi Jewish population, but we really know that mutation in the BRCA1 and 2 genes, they don't actually differentiate between different ancestry. And so across the population, mutations are something that we can see. We think that probably overall, maybe we can get up to, we think about around 1% of the population might have. And the very important part, which I think what we're trying to focus on today is that in the past it was really focused on women, but the risk, this is not, has nothing to do with male and females. It's like it's equal probability of having the mutation, whether someone is a man or a woman. How the risk changes is sort of like what the risks are of the cancer associated with that.
So I think for the audience out there, it's like it's 1 in 100. So I think we say 1 in 50 to 1 in 200 chance of getting having a BRCA mutation. Of course, if you have a BRCA mutation, the family is often 50%. So I think it's different, and it's really an important part is like it is called the breast cancer gene. I think we have to a little bit get over this. It's not a breast cancer gene. It's like it's a breast, pancreas, ovarian, and prostate cancer, and potentially colon, potentially gastric cancer gene, and potentially other cancers. So I think the awareness should be there. It's like Bess, you have been in this area seeing patients now for many years. What has changed? What do you see is the most exciting difference that we do now compared to, let's say, even 5 years ago?
Well, I don't know that I would call it exciting necessarily, but from a female cancer screening perspective, there's been a change in how we look at ovarian cancer screening for women. And when I started at UCSF, it was almost 5 years ago now, we were doing ultrasounds for women and blood tests to monitor for ovarian cancer. And over the last 5 years, that's completely changed. And we really don't, I think we're more direct that we don't have good screening for ovarian cancer. So surgery is a much better approach than relying on imaging. For men, one of the changes that happened a couple years ago, Julie or Marta will remember exactly when, was the recommendation to add baseline mammograms, particularly for men who have BRCA2. And I was going through my patient list. We've got about 200 males in our clinic, more or less. And we've had 2 patients diagnosed with male breast cancer on their baseline mammogram. And in both cases, they were not palpable cancers. In both cases, they were easily treated. And that was an important change because prior to that, we were relying on exams. And for many men, a breast exam is a very reliable exam. But for finding it even earlier, which is always our goal with any cancer, we want to find it as small as we can because the treatment's better. Adding the mammogram really added a lot to diagnosing breast cancer. It is a little funny. I have to explain to our male patients that when they get a mammogram that they're going to be seeing a kind of girly looking environment. But I've never had a patient complain that they didn't have a very professional exam. They did have a little bit more sympathy for their spouse if they have one who's been getting mammograms for years, which was kind of funny. Let's see what else. I think those are some of the bigger change, particularly for men. And then for pancreatic cancer, extending the number of people who are getting pancreatic cancer screening, I think is huge.
And I think I have to say, as Marta and particularly Julie probably heard me rant and rave about the fact that family history is not a good predictor of risk for pancreatic cancer. I'm really happy to see that the family history is no longer necessary for the recommendation for BRCA2 and ATM to get pancreatic cancer screening. I think it's really important to not rely on family history. So I think, of course, if someone has a family history of pancreatic cancer, that increases the risk, probably even more in awareness. But just because you don't have a father or mother or brother with pancreatic cancer, that does not mean you don't need screening. So I think the NCCN guidelines have been changed this January. Now pancreatic cancer screening is recommended for all individual with BRCA2 and ATM mutation. So, Cary, pancreatic cancer for BRCA1 is still not as clear. We still feel like there's more pancreatic cancer with BRCA2, but I think emerging data will suggest that the risk for BRCA1 and pancreatic cancer, there's a significant link there. Julie, do you want to comment on this a little bit on BRCA1 and pancreatic cancer?
I wanted to acknowledge, I think Gordon has his hand raised.
Oh,
I was just going to comment that it is a bit strange having a mammogram if you're a male. It's almost like going into a women's locker room. And but it's okay. It was strange. And it's also made me, as was stated, appreciate what women go through, because they have a much harder time getting tissue to take a picture of in males. But, I feel it's still very worthwhile.
And, it is a really a very significant goal of our program to really increase our male participants in the clinic. We still see, particularly in younger years, we probably see 80% of our patients, almost 85% of our patients are females. I feel like we need to change this, and I'm hoping by changing this, Gordon, you're not going to be the lonely guy in the mammography suite.
Okay, good. I hope so. I hope a lot of people feel okay doing it. A lot of men.
Okay, Julia, Marta, how strong are the recommendations for mammograms? I think we have gone back and forth over the years, right?
I think Beth really talks about this with our patients more, so I'll let her speak to that. And then I don't have an answer about the pancreatic, but I have some good food for thought. But I'll let Beth answer the mammogram question.
There's a recommendation to consider mammograms for men as a baseline. In the NCCN guidelines, it's not a strong recommendation. At UCSF, we have a steering committee where people who study breast cancer in men, who are experts in radiology and in breast cancer, we have together made a little bit stronger recommendation for our patient population. There are a few recommendations for those of you who I see in clinic. You're aware that there's a few cases where we exceed what NCCN guidelines say. So we considered NCCN to be the minimum in terms of screening. And there are a few situations where we have found, for example, mammograms finding male breast cancers, that there is a benefit in doing at least some of these baseline screenings. And I think somebody asked about BRCA1. Males with BRCA1 have a lower risk of breast cancer, but I have ordered ultra mammograms on men with BRCA1 based on the kind of exam that we have, if they feel that there's been a change in their chest wall, or if there's certainly a family history of male breast cancer.
Hey, Julie, you want to quickly weigh in on the pancreas and BRCA1, then have a question from the audience that I want to address?
Right. And I think this is, as I said, I don't think I have an answer, but I think this makes me think about a lot of the work that I'm doing. I'm on several groups with the American College of Medical Genetics, where we're really talking about how the next step of our understanding is going beyond looking at one gene. So we know that having an inherited mutation in BRCA1 or BRCA2 gives us these elevated average risks. But what we want to get much better at is knowing, for that individual person, are you on the high end of these range or the low end? I tried not to confuse you. I quoted you sort of one number, but when you open up NCCN, it's like this big range. So I think the answer is that even though the average risk for BRCA1 is 5%, it's entirely possible that there are some people who have higher risk than that. And I think the next steps will be figuring out what are the genetic and non-genetic and other factors that help us determine that, so that we can give people the appropriate screening without having, every single young person being, scanned up and down starting at age 30, but giving it to the people who need it the most. So I think that's my thought is just, I think I'm really interested in the ability to refine risk even beyond what we are right now.
So the question is like, the question, can you address how and when to talk to young people? Max, you're our young representative, like being a carrier, having seen people with family members having cancer. What would you recommend that how do we talk to young people?
It's kind of a cop out, but it really, I think, is situation dependent on the child. So I got tested when I was 19, and I wanted to get tested because I wanted that information. But my younger sister was 15 at the time, and I don't think she was in a position where either knowing that I was positive or getting tested herself would have been good for her well-being. So that was a thing I just sort of sat on for a couple years. And then, when she was 20, she wanted to get tested and was ready to get tested because, a lot can change very quickly for young people in terms of how mature they are and what their sort of state of mind is to get tested. So, I mean, honestly, the best advice I would give is just to be as honest with your kids as you feel they can handle, and to know that I think sometimes they can handle a lot more than you think, especially if they've seen other family members who've had cancer. And just understand that, they might not be ready today, but a year from now, things can change very quickly for young people. So just patience and understanding, I think, is useful.
And I think to weigh in here, I think Max, you also didn't share this with your younger brother, right? It's like you sat on the knowledge that you're positive, even with your younger brother, because he was not ready and he was not asking about being tested. There's nothing. Did you have conversations with him about this, or did he ever ask you?
Not really. I mean, I think sort of in passing, he again was just sort of not super interested in knowing. I don't think he was nervous about it or it was causing him a lot of anxiety. He just sort of wasn't all that. He was very ambivalent about the question. But then again, a couple years went by and all of a sudden it was a thing that he became a lot more interested in. But yeah.
And I think this is an important message for those who have kids. It's like it's interesting. You can see kids go from it's just not part of their interest, and then it changes. And then I think this is the questions of one of our attendees. Is like I intuitive my kids are BRCA positive. We have kept this from our 9-year-old son. The oldest now turned 18 and is worried about they're worried about telling her. So I think I feel strongly, having gone through this with my kids. I think your kids will tell you when they're ready. And as a parent, you may be anxious for them to know or for you to know, but I think the kids will let you know when they're ready. And I think going back to what Beth said is like with the girls though, it's good if that readiness comes a little bit before 25, because at 25 for girls we start screening with MRIs, and it's really hard to learn about your mutation, and next you get involved in this intense screening program. We have different discussions with girl about birth control, what type of birth controls, what's protective, what's not. I think having a little bit of preparation time for the knowledge about the mutation is really important. Cary, you're a little bit in this situation. Do you want to comment on this?
About when to tell the girls or when
to tell the girls and like
yeah, I mean, I think we've approached it where like you have a 50% chance. And, when it comes to questions around birth control or those sort of things, like, what would be a good thing or a bad thing related to your BRCA. You might have it, you might not. It's 50-50. And, as I said earlier, like at 18, I think my oldest daughter's going to want to know, but we'll see. Like, we're not going to push her, but I think she's going to be kind of in Max's camp around that age where she just wants to know and she wants to use that knowledge to adjust her behavior if that's going to be required. And I support that. Who knows how her younger sister will be. I also wanted to comment on one thing Julie said when we were talking about pancreatic cancer and new tests. I mean, Pamela knows this. There's lots of really exciting things happening with liquid biopsies. And for pancreatic cancer, there's some really strong early data that there's signals. For pancreatic, ovarian is still a real challenging thing to find early. But there's other things happening that's really just right around the corner, like polygenic testing and integrative risk scores, where you might in the future be able to say, hey, Mikey, my son, you know what? Yeah, it's 5% because you're BRCA1, but because of these other things that have happened, it may be higher than that for you, like 15%. So we're going to put you on a different path. Or breast cancer for some people with BRCA2, maybe they are even higher than that 10%. So, I mean, there's just incredibly powerful things happening with the science right now. So, but from a men perspective, I didn't treat, and I don't think any of us should really treat our boys different than our girls. Like, it's important to know for both, because if you have that stomach ache, you kind of start feeling something in your breast, boy or girl, if you know you have it, you can do something much earlier. So, I'd like to see every single person in the Bay Area in America that has a BRCA in their family get tested and just, know whenever it's the right time, but have a plan. But just even knowing that you have it, it's going to make you more aware. And I totally agree with Max. I have a buddy that just went through a similar thing. Like, guys, this is a generalization, but like, we fight through things. Like, but if you have a BRCA 1 or 2 mutation, you're not going to fight that long. You're going to go get that ultrasound or that X-ray earlier than if you didn't know that. So knowing if you have it, male or female, I mean,
and I think that also brings like the idea of say normalizing through a family history, right? Just talk about this as a family and not, when we were talking about when is the right time. Usually it's just like not just that being part of the family knowledge that this is something that is there, is something that is possible, and then adjust the way we talk to everyone depending on the level of curiosity or questions. I often, to discuss with my patients, your children kind of drive the amount. They tell you what they want to know and where they are. Don't give them extra information if they don't want it. Don't overwhelm them. Listen to the question they have, answer. Don't hide anything, because every time you minimize or hide something that is there, it actually often becomes bigger. It's sort of like the adults don't want to talk about this. It might be a very big deal. So this is something I need to be worried and scared about. The more open and the more you just talk as a sort of like, this is what it is, this is what we do, and it's nothing, not making it bigger and more scary. It's very helpful in families.
Gordon, you still have your hand up.
I have my hand up again to tell you. So I had one son that I told about the BRCA mutation, and they were adults at the time. And well, both sons actually, and one got tested and one didn't. And then about 15 years later, the second son decided to get tested because he realized that he had a daughter, and he did it for his daughter's sake, not necessarily that he felt at risk. So sometimes it's in males, we think we're invincible. I've got a nephew that's in the same situation, and it kind of reminded me, this webinar reminded me that I need to speak up to him, because his father, my brother, is positive for BRCA2, He didn't get tested because he said, I don't need to be tested. I'm not worried. But now he has a 3-month-old daughter for the first time. I think when I talk to him, he probably will change his mind about being tested for her sake.
So talking a little bit about another question from the panel. Can you confirm that these mutation can only be passed on via a parent? Therefore, if you have a BRCA mutation, this must have been passed on by a parent.
That feels like a genetics question. What I would say is essentially.
Sorry, I was looking at you, but you can't actually see that I was looking at you.
What was I going to say? So essentially, yes. I mean, if we think about how genetic change happens, we know that all genetic changes had to start somewhere. But for BRCA mutations, it's incredibly rare. This has been studied. It's less than 1% of BRCA mutations happen sort of spontaneously. So we do know that all genetic changes did have to happen spontaneously somewhere in our kind of like human history. But and for some other genetic conditions, it's actually very common. But for BRCA, it's very, very rare. I think it's actually quoted at like 0.1% or in that range. And so essentially, yes. But there are times where, and this is a conversation Dr. Munster and I've had over many, many years, that sometimes these mutations do hide out in families that are small families that don't talk to each other, families where people died for other reasons, families where this came from the father's side of the family and he didn't have cancer or didn't have cancer until he was older. So that can be the reason why it isn't obvious that it is inherited, but it pretty much always is.
And I would like to add here that today, we have been focusing on the BRCA mutation, the BRCA1 and 2, but really we follow men with other mutations that increase the risk for cancer as well. And the sort of same apply for the vast majority of conditions we see, where generally speaking, it's something that is inherited from a parent when we talk about other genes like ATM, CHEK2, PALB2, the situation is very similar as well.
Before I go to the next question from the audience, I want to talk a little bit about the positive things sometimes from knowing that we have a mutation in the family. So we see a lot of young women in the clinic of breast cancer. And they don't have any mutation, and the children ask us, what is our risk? And we don't think we have a good answer. Whereas with my daughter, testing negative for the BRCA mutation is like, as you said, Cary, that burn is off her shoulder, right? She's like, her risk for breast cancer is not completely zero, but it's much, much lower than if she had the BRCA mutation. So the opportunities with testing comes also from the fact if someone is positive, we have a pretty good screening program now. If someone is a true negative, meaning the mother or father had a mutation and the child does not, which we call a true negative, that cancer burden is way reduced. And I think a lot of family members don't quite recognize how powerful this is to know about these mutations, I think. And I think, Cary, if the children in your family that are negative do not need to be screened for pancreatic cancer at a young age, right? And I think that must be pretty reassuring. There's the question is like, I'm a male, I'm 42 years old, I have a BRCA2 mutation that I discovered through 23andMe. That tells me that this is a Jewish founder mutation because 23andMe has only very limited BRCA testing. And I like to urge anyone not to do 23andMe BRCA testing unless you're from an Ashkenazi Jewish background because the other mutations are not tested there. Some 42 family members have prostate cancer and one had pancreatic cancer. Bess, I advise this individual to come to see you in clinic, what would you do for that 42-year-old male?
So the first thing we'd start talking about is starting prostate cancer screening with a PSA. and then based on the initial PSA, make any recommendations for additional screening. Because of the family history of pancreatic cancer, when we would start screening for pancreatic cancer would depend on when that relative was diagnosed. So generally we start at age 50 or 10 years before the first diagnosis in the family. So if they had a relative who was diagnosed at 55, we'd start at 45. But even if we're not doing screening, we're going to talk about the kinds of symptoms that people have with pancreatic cancer. And we want to create a really safe environment where people feel like they can call with, I have a weird symptom, and know that we're not going to blow them off. We're not going to say, oh, there's no way in the world you could have pancreatic cancer. Don't worry about it. We are going to always, on an appropriate symptom, order the imaging to rule out that cancer. And so that way people don't have to worry about the symptom they have. We're going to make sure they don't have cancer, set their mind at rest, and then tell them to go see their primary care provider and figure out why they have the symptom. We start educating on male breast cancer. If it's a BRCA2, we talk about melanoma and so on. And then we also talk about healthy lifestyle. So I had a patient who came in who was in his early 40s, and he smoked cigars once a week. And we had a long conversation about the effect of nicotine on the pancreas. And I suspect, I might be wrong, that he's going to stop smoking. So there's no age too early to start turning around some of those lifestyle choices that can increase people's risk.
Okay, putting Max on the spot here a little bit is like, and Max, you can say, I don't want to answer this, or bypass. Like, you're 25 with the mutation. It's like you're embarking on dating, getting married, creating a family. Like, what would you advise, and what would you think a young person, when do you bring this up that you have a mutation? I know this is a difficult question, it's a very, very challenging question, but I think this is something that probably goes through many of Gordon's and Cary's children as well. Like, when do we bring this up?
On the last panel I did, the person said not on the first date. That would be my advice as well. Probably not first date material, but it's not something you can just not bring up. I don't think that would be ethical or responsible to just not tell your partner that information. But I also think, again, me personally being a child of someone with a BRCA mutation, I'm very grateful that my parents were not deterred by that information when they decided to have me and my siblings. And I would hope that the person that I'm with, and I would ensure that the person I'm with also would not be deterred by that same reality, because I'm very grateful to be alive, and I think that I've had a pretty good life so far. And I don't think that this is the kind of thing that at all would make someone want to, or even consider, not having children or not having normal relationships or anything like that. It's another thing, it's one other thing in life. Everybody's different. So all I would say is just be honest, and it's a thing that you need to talk about. Again, I don't think it would be ethical to not talk about it, but I also don't think it's the type of thing that you need to change the way you look at relationships or dating or marriage or any of that sort of thing.
Thanks, Max. That's very thoughtful. And I really appreciate you speaking to this, because I think it's a difficult discussion. Cary, do you see this with your kids? Like, did Mikey struggle with this discussion with his wife?
So he didn't. I think, like Max suggested, I mean, they started going out freshman year in college. I think he learned about his mutation junior year in college, something like that. So she knew from that point. They had a baby before he had cancer. Actually, she's pregnant again. She didn't even want to know. She was like, you know what? You're amazing. Our baby's amazing. This is maybe it's not a bad thing. You know what I mean? If it doesn't kill you, maybe it's not a bad thing. But they had to, from an insurance perspective, do IVF. They had to check, and see if it was a BRCA positive, and it was, the insurance wouldn't pay for it. So they know their next child will not have a BRCA mutation. They don't know about their first child. So it was never a thing for her or them. And she probably knew within 5 minutes of him getting told that he's BRCA positive, but they were probably going out for a couple of years by that point anyway.
And Gordon, what do you see with your grandchildren?
Yeah, I haven't really had that kind of discussion with them.
You're not part of the dating life of your grandchildren?
I'm on a need to know basis. But I have a stepdaughter who went through in vitro fertilization and did a lot of genetic testing because the donor was of Ashkenazic Jewish background. So, my comment is that I think we're in the early stages of learning about genetic diseases and mutations that predispose us to a higher risk. But if we're thinking about the dating scene, which I'm far away from, and I'm way beyond the reproductive stage, so it's a bit irrelevant for me personally, but for me, it matters for my family and for society. What about rheumatoid arthritis and some of the other diseases? We don't check out to see our health pedigree before we choose our mate. So how is this really different? There's a lot of chronic diseases that are just as nasty as cancer. And some don't have any good cures. And we have some real good results with cancer treatments and diagnosis today. So I don't think it should be a problem, but it may be for some people.
But I think I would echo what Max says. It's like, it's the, I think you should be honest, and then we all make choices, right? It's like in our spouses, and I'm pretty sure my spouse would have been able to handle my BRCA mutation probably, but so I think these are important discussions to have. It's like, so that being said, though, there is probably some real ramification, Julie or Marta. If someone does have a BRCA mutation, we know there's a 1 in 100 or 1 in 200 chance that the spouse also has a BRCA mutation. What are reasons to test the spouse? It's like there are reasons to test the spouse, right? So, Marta, you want to take this, or Julie?
Yeah. Yes. So we do at this point, we do recommend testing the spouse or the other biological parent to a child, regardless of family history. As Julie was mentioning before, sometimes this mutation can kind of hide in families and might not be obvious. But if both biological parents do carry a mutation, especially in the BRCA2 gene, there's a 1 in 4 chance of a child having a more severe condition with childhood onset called Fanconi anemia. This is a condition that can cause some skeletal anomalies since birth, in particular in the thumb, in the forearm, in the spine, and other bones of the body. But it's also associated with difficulty in the production of blood cells and can result in bone marrow failure as a child. So while the conversation we've had so far is more like, how impactful is cancer? What do we do about that? We're talking about adult onset condition. Fanconi anemia is something that in a large number of cases has serious implication in childhood and can be life-threatening. And so we do recommend having a conversation about this and understanding, and the testing of the partner is really not for cancer risk, but for reproductive risk assessment. this is like established for BRCA2. For BRCA1 is a little bit different. Until not that long ago, we thought it was not possible to have a child being born with two mutations in the BRCA1 gene, and we thought individual with BRCA1, if both parents had mutation, might have had a higher risk of having miscarriages. We now know that it's a possibility in certain circumstances. So regardless, we always talk about testing for the partner, whether is a BRCA1 or BRCA2 carrier, the patient in front of us. So we have in-depth conversation about all of this.
And thank you for that, Marta. And then in addition to this, I think as a medical community, and this happened to me in clinic, I think Beth, you're well aware of this patient. We have a male who has a BRCA mutation we have taken care of for several years. And we tested pretty much his entire family and didn't test the spouse. And a year ago, she presented with ovarian cancer, and she actually has the exact same mutation that he has. And we just never thought about her. And I think we all felt pretty terrible being remiss and having an opportunity of testing a spouse. And I think, Cary, something similar happens in other families, right? So we focused on the family members we know have the mutation, and we just leave the spouse out. And I think it's important to test the spouse for making sure that there's not a risk for Fanconi's anemia, but also just to not have surprises, because it is a mutation that happens more often than not. Julie, how do we handle spouse testing? We haven't made as a program, we actually not have addressed this, right?
I think we address it on a case-by-case basis. As you said, I think we tend to talk to people more if they are actively, they're like, we are trying to have kids, and we bring it up. I think it's a fine balance. I think we're, Cary mentioned this, we're at a time where there's so much change happening technology-wise, and I think policy-wise. So we do handle it, and we do see partners. Sometimes they have a family history, sometimes they don't. We also want to be, if they are thinking about having kids, realize that cancer test BRCA2 is not the only gene that could affect recessive disease. So a lot of times it's a kind of a partnership between us and the prenatal genetic counselors. So we are doing it, but I agree that we're in this gap right now where it may be everybody who's getting tested at some point in the next 5 to 10 years, but we're not quite there yet. And so I'm trying to find the right balance. But actually, we do see quite a lot of people who come in because of their family members. And as you said, sometimes we do find really important information that I heard from a lot of people, and I've heard that sentiment in other forums as well, that, having one mutation in these genes for a lot of people is not something that would change the way that they think about having a family. But we know that having both partners be positive with the risk of a much more severe condition that could affect young children is something that sometimes doesn't mean that people can't have kids or shouldn't have kids, but may change the way they decide to go about it.
Thank you. On a more forward-looking note, so Gordon, what's the most pressing gap in knowledge that you think we have for you? What is the biggest question for you that we can't answer when you come to clinic or when you look at those panels? What do we need to focus on next?
Well, I think it's the one that's we have some promising diagnostic tools around the corner, the cancers that are not so easily today detected, like pancreatic cancer. And we see them only after people are pretty far along in general. So the diagnostic techniques need to be generally available. I think that's primary. I mean, prostate, for example, we've come a long ways, I think, in that area. And then for females, ovarian cancer is still a real tough one. So I think diagnosis is screening to speed the diagnosis.
Cary, what about for you?
I mean, you know my perspective, and it's also very similar to Gordon's. I mean, I think the big gaps right now are ovarian and pancreatic, right? If we could have a little magic blood test where we can find those in stage 0 or stage 1 or even stage 2, we would improve millions of people's lives. Like it would change these diseases, not just BRCA, but all the homologous cancers out there. So I'm thinking that's really great, and that's not probably too far away. And then, there's even bigger macro population tools like integrative risk scores and some other things Julie kind of alluded to, or we may just test every human and do a full genome test and do all sorts of other things, integrate with their electronic health record, and really start predicting not just cancer but other diseases as well. But if we could get a lot smarter earlier about pancreatic and ovarian, that's massive. It's massive for my son on the pancreatic side and others like him, and my daughters and all daughters out there. That's what you really start worrying about, right? Breast, if you're diligent, there's some good solutions. Ovarian, it's like have a fallopian tubes removed, or maybe even worst case, both fallopian and ovaries. Like that's pretty brutal, but that's the state of the art, and that's the safest, best thing to do today. So how do we get these things earlier? And I know Pamela and I are committed to this every single day.
You, Max, what is your burning question for the future? Like you're sort of like in just scot-free, like nothing is. No, I don't need screening right now. I'm 24. It's like, what's the burning question for you?
I mean, for me, kind of just like when do I start really like focusing on it more seriously? I mean, I think I'm sort of generally healthy, but also pretty laissez-faire about the whole, proactive testing and that sort of thing. I do smoke cigars on occasion, so that is probably a thing that eventually we'll have to stop. But at some point, I think that's the big question for me is when does it uh, become more existential versus like something that's sort of off in the distance?
And I think what we are really what we really focus on the program is like like can we get better testing? Can we get earlier testing? Can we get tests that are easy accessible? Because the MRI testing for pancreatic cancer screening is great, but someone who lives in Reading, this is going to be a lot more challenging. Like, so how can we convert some of these imaging tests into blood tests, and can we add blood tests to the current screening? I think I think we can do this in the next 5 years. We can start getting really research up and going, and Gordon and Cary, you guys have been instrumental in helping this program and like shaping research, and my team has been amazing in doing this, and I think we'll have a better handle on those questions in the next decade for sure. Hopefully in the next 5 years. Bess, what do you need in the clinic? Like
we are constantly looking for more information to tell people to help them reduce risk. So what diet, how much exercise, and at Max's age, what can he do that in 20 years is going to pay dividends in reducing his risk. So the more that we understand the non-genetic contributors to cancer risk and things that people can modify, they can change, like diet, like smoking, like alcohol, like many things. Those are the things that I really look to talk to people when they are young about, when they want something they can do to affect their risk. And I want to give them something that can help them do that.
Marta?
I think Julie has already alluded to that, but I'm really looking forward to the day where we can move past the single mutation and I give the same risk to everyone, not just with a single mutation, but even, we have multiple people with the same mutation and such different family history. And I'm really looking forward to the day where we are smarter and better at understanding what else. We know that the mutation alone does not is not all, and we are just starting to scratch the surface. Cary mentioned polygenic risk score and things like that, but we really are missing a better understanding of why the same mutation behaves so differently across families. And I'm looking forward to the day where I can be more personalized really in meeting with a patient and saying, not there's a 20 to 60% risk of prostate cancer, but in your family, this is what we think the risk is.
Julie?
I think the good things have been said, but I particularly think a lot about what Cary was saying. I think we've come so far. I mean, 30 years of research, and absolutely everybody on this panel has said that they are better off for knowing this. And yet, I sometimes feel like I tell somebody, you have options. And I also feel like all of these options are not great. Like you probably don't want to choose any of these, and particularly not alone, but I think particularly, they recommend our challenge with detecting ovarian cancer early, and with BRCA1 having to talk to women as young as 35, 36, 37 about removing their ovaries and fallopian tubes, which is truly potentially life-saving because of the nature of ovarian cancer, but the trade-off that they are making with their hormonal changes, potentially running up against their reproductive years. I would love to see better options. I think the research on removing fallopian tubes only is really, really interesting. And we're going to see those studies are being done right now, but we won't see those results for another 10 years. But if I had to pick one, which I want them all, but I think I would probably pick not having to talk to people in their late 30s about removing their ovaries and fallopian tubes. It's good to have that option. It'd be way better if we had a better option for them.
Good, we're almost at time. Any parting words, Max? Anything you want to add?
Not too much comes to mind. I think the main thing is just like, especially if you're thinking about how to talk to your children about it, is just, meet them where they are and understand that like the way that a parent may feel about something might be very different from the way that a kid feels about it. I know for my mom, that was certainly true. I think she expected that I would be a lot more hesitant about it, similar to my siblings, but I wasn't. I think the opposite could equally be true, that for a parent, it may feel very like practical, like, hey, let's just get the answer to this question. But for a kid, it might be something very existential and the source of a lot of anxiety. So just understand who your children are, basically, and try and make sure that you're giving them answers to questions they're asking. You're not giving them information they're not looking for, or answering questions they aren't asking. But that's all I have.
Thanks, that's really helpful. Gordon?
I think a very important thing is continuing to get the word out to people about the genetic impact on certain cancers and the options they have when they know about it and can put together a surveillance program and get early detection.
Cary?
I'm going to take a more personal route and just want to express my gratefulness, my appreciation for you, Pamela, and your team, and what you do for me and my family and everyone in the UCSF cancer community. So you are beloved, and just thank you for what you do.
And as you know, it takes a village and it takes all of us. And I think we have an incredible task ahead of us and an incredibly rewarding road. And as you may know, we are pledging to build a big Hereditary Cancer Alliance, trying to bring together the many institutions of the West Coast. I think that takes all of us, and I think it's exciting. And so with this, thank you for your candor. It is really nice to see 3 generations of males facing this problem and really showing that you can live with this mutation, right? And we can live with this mutation. So with this, thank you all for giving up your evening, and thanks the panelists for joining in, and have a great evening.
Thank you, everyone.
Bye-bye.